approach of the critically ill children with COVID-19, the long and winding road. Before we start, I would like to invite the President of Indonesian Pediatric Society, as well as the President of Asia Pacific Pediatric Association and Standing Committee member of the International Pediatric Association, Dr. Aman Pulungan, to deliver his keynote speech. Dr. Aman Pulungan, the time is yours.
Thank you, Dr. Anton. Ladies and gentlemen, our distinguished guest speaker from NUS Singapore, our neighbor, Dr. Jacqueline Ong. I hope I pronounce your name right. I have a lot of friends actually from NUH, but I'm trained as an endocrinology and genetics, so we have a lot of collaboration with your head of the department, probably Professor Lee Yung Seng. I was a fellow class with him. And also Dr. Riri, the head of our task force for the emergency medicine in pediatric, and also Dr. Anton and all the participants of this webinar. Is Dr. Kneider here yet, Dr. Anton?
Dr. Kneider is not coming yet.
Okay. So, the thing is, I think this is a quite good webinar about sharing about experience. We know the pandemic, of course, when we talk everything about health, especially health in children, we should relate to what's the situation in pandemic. The pandemic in Indonesia, in the world, start from December 2019, but in Indonesia, it starts from March 2020. So it's been about 9 or to 10 months. But we are not going anywhere yet. We know Singapore, we are doing really good, and school already start. But in Indonesia, we are not even reached the first wave. So every single week, we have a meeting in our society, and we still have a lot of cases. And the mortality for children in Indonesia, having said that, probably our mortality is the highest in Asia Pacific and probably in the world. So, speaking about mortality, of course, it's related to the emergency medicine. But the problem is in Indonesia, probably Dr. Riri will share, and also the other speaker will share, and also Dr. Anton also is intensivist. We didn't have enough time to save our children, because the highest mortality is from under 5 and also from under 1 year old. And most of the time, when they come to our center of the hospital or referral hospital, is a bit quite late. So not even 48 hours or 70 hours, or sometimes not less than 24 hours, we just cannot save them. This is the problem. So a lot of things that, even though we have a lot of intensivists, but not enough, Dr. Riri will mention, because we have 34 provinces, 17,000 islands. Every single year, we have almost 5,000 newborn, almost similar to the population of Singapore, the newborn. And in total of the children right now, almost 90 million. So we are the second, I think, after India in Asia Pacific, and also in terms of population of children, probably in third after China and India, probably. So this is something that, we are really glad that the collaboration between Singapore, European society, that we can share. Of course, we have to learn a lot from you, what you've been doing. And the epidemiologic report, the situation right now in Europe, they are going to start the third wave. In fact, I have my student, my former student right now is the resident of the emergency medicine working in Amsterdam. She told me that right now, almost all ICU in Amsterdam are full. So they are going to then start the restaurant also. Some town in Netherlands are closed, and some country in Europe they start doing the lockdown again. So this is what we call this inequality, even in treatment, tracing, and also testing, and also reporting. So this is something that I think we should have to discuss. And I would like also to highlight about the positivity rate also in our country is quite high, about 14 to 5%. So the positive number of children in Indonesia is quite high. And as a society, Indonesian Pediatric Society, we are working right now really hard with our member. And we lost also our member. This week, we lost our member from one of the cities in Sumatra. And even the president of our one chapter in Sumatra right now still in the hospital due to COVID. So a lot of our member also infected by COVID and put it in the ICU. And even we lost of our member. So the implementation of the early detection for this COVID, I think this is the most important thing. Yeah. What we have to do, I think, I don't know about what's happening in Singapore, probably early detection also to prevent them to become severe. And I don't know because this is really short webinar. School already open in Singapore. Maybe you can share also what's happening when you start your school. Because we have not started our school yet. We're still afraid. But when we started, we know all the report, all the articles said, when we start the school, we have to prepare with our ICU, our intensivist, our isolated room. So when we start the school, we know Dr. Riri, Dr. Anton will work really hard to prepare everything. Yeah. Because some school, the boarding Islamic school already start, and right now we know some of them to be cluster anymore. I think this is just the opening. I'm not a speaker. I'm not the expert for this, Dr. Anton. I hope this webinar will have a benefit to all of us, and we can share, we can learn a lot from both of them. Yeah, I know these two countries. Yeah, if in fact that I don't know, Dr. Naider is not here yet because I was trained as pediatric endocrinology in Amsterdam, so I know quite well the country in Netherlands, but he's not here yet. But in Singapore, of course, everybody knows about Singapore, especially about NUH. Yeah. Thank you very much again, Dr. Dr. Jacqueline, for your time and also opportunity to share your knowledge. And please, yeah, enjoy the webinar, and I hope we will get benefit of this webinar. Thank you again, Dr. Anton, and thank you everybody. Thank you, Dr. Ong. Also here, I saw here Dr. Yogi and Dr. Riri. Thank you.
Thank you very much, Dr. Aman. We will have 4 distinct. Please introduce the 4 speakers. The first speaker will be Dr. Yogi Prawira. He is a pediatric intensivist consultant, worked in the University of Indonesia, Faculty of Medicine, and Dr. Mangunkusumo Hospital. He has passed the fellowship trainee pediatric and congenital ICU and in National Heart Institute, Kuala Lumpur, Malaysia, 2015. Right now, he's the current position is now he's the head of pediatric unit of University of Indonesia Hospital, and he is also head of task force COVID-19 Indonesian Pediatric Society. Dr. Yogi will talk about the role of the task force in managing the COVID-19 pandemic. The second speaker will be Dr. Riri Malis, consultant of pediatric critical care since 2011 and a PhD in the University of Indonesia in 2014. The chairperson of the Emergency and Pediatric Intensive. She has a lot of publications and presentation internationally. About children with COVID-19. The third speaker will Dr. Jacqueline Ong, pediatric intensive care since 2017, and she has she's a senior consultant in the Department of Pediatric, National University of Singapore, and head of Pediatric Intensive Care Unit, University Hospital Singapore. Since 2014, she's the assistant professor of the Department of Pediatric, National University of Singapore, and also since 2013, she's a chairperson of Global Aid Program Funds, Department of Pediatrics, National University Hospital, Singapore. I think she also has a lot of position internationally, as well as many published papers in international journals. The last but not least speaker will be Dr. Martin Neighbor. Dr. Martin Neighbor is I'll show you the education. She's graduated from the Erasmus University, Rotterdam, the Netherlands, with cum laude in 1998, and a PhD at the year 2000, also from the Erasmus University, Rotterdam, Netherlands. She is now appointed as the Assistant Professor of Pediatric in University Groningen, the Netherlands. I think he has lots of other professional positions, for example, such as the Pediatric Acute Lung Injury International Conference panel members, and Pediatric ECMO Anticoagulation Collaborative, the World Federation of Pediatric Intensive and Critical Care Society Research Consortiums. I forgot to tell you that Dr. Jacqueline Ong will talk about the ECMO in cardiac and respiratory support of COVID-19 children, and Dr. Neighbor will talk about the caring of the critically ill children with COVID-19, the European Society Pediatric Neonatal Intensive Care recommendations. Okay, now we proceed with Dr. Yogi. Dr. Yogi will start his talk on the role of task force in managing the COVID-19 pandemic. To Dr. Yogi, the time is yours.
Thank you very much, Mr. Moderator. My role models, my teacher, Dr. Antoni Sujadi. Distinguished speakers and dear colleagues, this afternoon I would like to present about COVID-19 in Indonesian children, the role of Indonesian Pediatric Society Task Force. Most of you might be familiar with this graphic. As we all know, Indonesia announced the first case of confirmed COVID-19 on the 2nd of March 2020. And we know that up to today, we already have 474,455 confirmed cases, with overall mortality 15,393 cases. What strikes me most from this graphic is the doubling time of accumulated cases. It took us 5 months to reach the first 200,000 cases from zero, but then only took us 6 weeks from 200,000 up to 400,000 cases. If we don't do anything about it, we might end up like the United States in an even more catastrophic condition. If we see from this slide, we can see that the last 13th of November, Indonesia recorded the new daily case up to more than 5,000 per day. And the case fatality rate is around 3.59%. Our daily test, this is the good news, already reached up to 37,892 daily tests. But then the WHO standard is 38,500 tests per day, so still below the WHO standard. And our positivity rate still reached up to 14.37%, while the WHO say that the local transmission is already controlled if the positivity rate is below 5%. And we still have a long way to go, because most of the cases, with the suspected cases, still not tested. And this is the highest provinces with the highest confirmed case. For those of you who live in Jakarta, East Java, and West Java, and all of these highest province with the highest cases, there are two things here. We have to consider this as a good thing, because it means that the local capacity of the testing is already increased. But then the bad news is the transmission rate is still high. From these slides, we can see that the proportion of Indonesian children that between the overall confirmed cases of COVID-19 in Indonesia reached up to 11.3%. This is considered higher than any other countries. Most of the countries, the proportion of the children with a confirmed case of COVID-19 is less than 5%. So our children that confirmed with the COVID-19 will be around 53,613 children. And from this age-based mortality chart, we can see that the case fatality rate for children is around 0.45%. This is considered lower than the adults, but then we have to compare it with other children with the same age group in other countries. And Indonesia still considered the highest case fatality rate for confirmed case in children in the Asia-Pacific region. From this demographic comparison between the India, the Andhra Pradesh and Tamil Nadu province, and the United States, we can see that it's comparable, the age distribution, also the reported age distribution and the incidence strength by age. But then the proportion of the mortality in the United States is higher as the age group increases. And also from this slide, we can see that potentially our children below 18 years of age, because they have quite a proportion of the confirmed cases, but very low mortality, it will be a potential for the spreader. So children might be a potential spreader. And from this table, we can see that this is an age-based case fatality ratio. Even in India, they have lower case fatality ratio compared to us. If Indonesia is around 0.4, 0.5, in India, they have 0.16 case fatality ratio below 5 years of age, and even lower, 0.054% between the age 5 to 17 years of age. And also from this slide, we can see when we reach certain ages, more than 65 years of age, the case fatality rate of the male confirmed case will be double the female. Yeah. We can see over 65, the CFR is 11.5 in male, but only 6.67 in female. And we have our own data from the Indonesian Pediatric Society COVID-19 registry, updated last 16th of November 2020. Our suspected case reached up to 31,863, with the total confirmed case is over 26,000. It's lower than the government data because we only record the hospitalized children that managed by the pediatrician. And the case fatality rate is comparable with the government, 0.4 from the total national data, and from our data from the Indonesian Pediatric Society, 0.54%, the case fatality ratio for confirmed case. And as Dr. Aman previously mentioned, this is the age distribution of the confirmed COVID-19 death case. The highest will be below 1 year of age, and then below 5 years of age. And from our data, from overall 84 patients, the biggest 5 comorbidities will be malignancy, cerebral palsy, tuberculosis, congenital heart disease, and severe malnourished. And compared to this data from the European CDC, we can see that the hospitalized mild cases have a lot of comorbidities, but for the severe cases, 71% of them was previously healthy individuals. And according to our protocols, we have 5 clinical severity classification, from asymptomatic to mild, moderate, severe, and critical. And according to this, the left side is from the referral hospital in Indonesia, and the right side is from the field hospital, the shelter. We can see the clinical condition in hospitalized children is different from the referral and the shelter. In the referral hospital, 55% admitted with a severe condition, even 35% already critical. So the case fatality rate is quite high. But in the shelter and probably in the community, around 99.2% asymptomatic and mild symptoms. Yeah. So this is quite striking. So meaning most of these children, they probably have a very mild symptoms. And as a pediatrician, once we are face to face with these children, sometimes we fail to recognize, and sometimes they can spread this virus among us. And this is based from the CDC, who have the acute COVID and COVID-19 associated MIST. The acute one, most of us already recognize. Around 85, even 90% of our children that contracted with COVID-19 will show mild symptoms. And a small proportion, less than 2%, have a very severe symptoms. How about the COVID-19 associated MIST? There's three conditions: febrile inflammatory state, and the Kawasaki disease-like illness, also the severe MIST. We know that the first paper regarding this MIST is the United States. And they mentioned there is a post-infection complication of the virus rather than acute infection, at least in some children. And how about the epidemiology? They age between 8 to 11 years. And then most of the patients previously is a healthy child, but several patients have obesity and asthma. So we have to consider obesity and asthma as a comorbidity. And there were no reports of MIST from China or other Asian countries yet, but we'll see after this. And probably Dr. Lily will enlighten us about the MIST in Indonesia. And 60% of the MIST patients, they have negative PCR. So we have to advocate this to our government, because one of the reasons for the dispute claim is this negative PCR. But we know, because it's post-infectious disease, post-infectious events, so most of the children with MIST will have negative PCR, but their antibody already built up. So we have to check for the antibody. Indonesia already reported a series of cases. This is from the our colleague from Bandung, Dr. Dadang and his team, a 6-year-old male with a infection between COVID, MIST and dengue. But the patient's, this is a previously healthy child with a fever for 5 days and abdominal pain. There's no history of traveling of contact with COVID-19 patient. The patient still active 2 days before admission, but the symptoms abruptly worsened afterwards. Initially, patient was diagnosed as refractory septic shock, already given aggressive fluid resuscitation, broad-spectrum antibiotics and inotropes, but the hemodynamic instability progressed and the patient deceased within 14 hours since admission to the pediatric emergency unit. And we can see the X-ray, it's still a good X-ray, so there's no signs of pneumonia. And according to the definition, there's a bit of difference between the RCTCH, CDC, and WHO. You see, these patients from the West Java is between 0 to 19 years, and the fever lasted like more than 3 days. The patient is hospitalized with the multi-organ system involved, and the ferritin level is very high. There's a hyperferritinemia. Also, the patients have positive by serology, and these patients also have a lung infection with the dengue and no obvious probiotose. So the definition of MIC already included. And the last few months here, we are hearing the debate between economists and some public health specialists between lives versus livelihoods. We know that infectious disease and this global governance failure will have a lot of things that will change our social stability. All of this will have interconnected with each other. And the question is, should it be a debate or we have to come to one conclusion? We know that when we infected with COVID-19, it's not only about survive or not survive. We have survivors that have these unresolved symptoms. survival that they reported symptoms up to more than 1 month, even 3 months after they discharged from the hospital. They reported fatigue, dyspnea, anosmia, headache, diarrhea, abdominal pain, even chest pain and confusion. So, if some government has stated about the herd immunity, it's not only about the low mortality, but the absolute case, and also about these unresolved symptoms. We will have a populations, a sick populations, if we not doing anything to stop this pandemic. And there are several tips to stay productive during this pandemic. We have to obey the rules. This is number one. Even if you're let's say an influencer of someone that have positions in the community, you have to obey the rules because people look up onto you. And there are 3 do's still. We know that we have to wear masks, we have to safe distance, keep safe distance 1 to 2 meters, and frequent hand hygiene. And we have to avoid the 3 don'ts here. We have to avoid the crowded places, the contained environment, and also the close contact or close conversations here. Let's say you need to speak to other person more than 15 minutes, less than 1 meter, then do it in the online. Do it online. And nutritious staple, you can have all the vitamin as long as there's an evidence to it. Stay at home if you don't have anything urgent to do, and you have to keep your mental well-being. Try to keep socially active and develop an online working group. So we come to the conclusion. With this situation, the logical conclusion will be the government must do whatever it takes and spend whatever it costs in the interest of our health and our collective wealth for the economy to recover sustainably. And it's not about lockdown or no lockdown, but if governments, all of us, fail to save lives, people will be afraid and they will not resume doing all the economic activities. As both economists and public health specialists put it, only saving lives will save livelihoods. The more we learn about coronavirus, the more questions arise, and COVID-19 is a master of disguise. So we have sometimes we're still learning, we're still on the learning curve. But we know this is an infectious disease and less severe symptoms in children, but beware of rapid and progressive deterioration leading to death, especially when we are dealing with children with comorbidities. And we know there is a post-infection COVID-19 in children. It's MIC, and in Indonesia, we already reported more than 10 cases about this MIC. So with all these uncertainties, our best strategy is prevention. Thank you very much. And I would like to commemorate our volunteers. We know that up to today, we only have 161 doctors that already deceased, and 140 nurses and 9 dentists during this pandemic. So I would like to ask all of us to try to make this health protocol, the 3 do's and 3 don'ts, into our new habit. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Yogi, for your very clear presentations. The next speaker will be Dr. Riri, and she will explain severe and critically ill children with COVID-19 best practice. To Dr. Riri, the time is yours.
Thank you, Dr. Anton. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everybody. First of all, I would like to thank you and very honored to my teacher and my mentor, Dr. Anton, who will be the moderator today, and Dr. Aman, who is the president of Indonesian Pediatric Society, to let me attend and participate in this prestigious online webinar. I would like to share and discuss to all of us about the severe and critically ill children with COVID-19, what is the best clinical practice we can do. I'm already thanked to Dr. Yogi as our chief and head of the task force pediatric COVID-19 of Indonesian Pediatric Society, because have explained it clearly to us the burden of this COVID-19 in pediatric and what is in the circumstance of the severe and critically ill children with COVID-19. Maybe we can take a look at the history and the process about the developing the clinical approach and what the impact of the pandemic to the clinical practice, what we have learned and face off in daily practice, and identify the opportunity to build and develop the guideline. From the literature and what we have in the world now, you can see history of the timeline of the pandemic since 1918 and until now in 2019, the pandemic of the COVID-19 or the SARS-CoV-2 is a very make us to aware. We can see the timeline. It's a globally circulating virus afterward, and we can see what happened since the pandemic and outbreak, like Dr. Yogi have explained in Indonesia. In early of March, Indonesian government formally reported the first 2 cases in Indonesia, and 1 week after that, Indonesia reported the first death case in Bali. This is the last situations. I think I'm not repeat it because Dr. Yogi have explained it clearly for us. And as the pediatric critical care perspective, Dr. Joseph Baron, on the early of the pandemic, have arrived what his concern about on becoming is we are a COVID-ologist as the from the intensivist perspective, who would think that we would consider ourselves as an expert of an illness that we all don't know almost nothing since we are in November and when continue to December and almost 1 year, and we continue to the next year 2020. What happened in the pandemic? Is it increasing or still in the status quo? Since the beginning of the pandemic, the true incidence of the pediatric COVID-19 is unknown. We are sad to say it is unknown because it's very in reporting, and it is I present the case study. This is a very beautiful study conducted by Dr. Sebastian Gonzalez and the co-worker. The case study is a cohort study of the children below 19 years old, and the criteria is severe or critical COVID-19. They limitation critical care in the requiring ventilations on a non-invasive or invasive, and required and accept active support or CRRT, and the study is still ongoing from April. They plan to until this December in this year, and it involves 60 centers from 20 countries around Europe and United States of America, and we can see only 17 children that came from 10 PICU include this around the countries. and they found it very heterogeneous symptoms. What we can see in the right side of this slide, the baseline characteristic, mostly half need the respiratory support with the symptoms of mostly more frequent of fever and cough, and the laboratory signs of the hyperinflammation like leukocytosis, elevated of the dimer, increasing procalcitonin or C-reactive protein. And the case study, they found and they have reported that most patients require respiratory support. Half of them need invasive mechanical ventilations, and most of them get pneumonia, and ERDS were common, and vasoactive infusion were frequent. Only few they found suffer myocarditis, and it's frequent comorbidities but low mortality and short PICU stay. And generally, they reported good outcomes compared to adult. And what happened in the UK? Dr. Patrick Davis and the co-worker published in around April to May. It's a multi-center observational study in UK. They recruit and get 78 patients who admitted in PICU required critical care intervention and treatment, and half of them get mechanical ventilation, either non-invasive ventilation or invasive. And most of the patients were treated with fluid bolus or vasoactive infusion, like we can see in the right side of these presentations. And the demographic and clinical feature is very interesting, because they found from the 78 patients as a subject, the median, mostly in the adolescents and pre-adolescents age, and the median age was 11. And we see non-comorbidities is the more portions, is almost 78%. And what we are interesting is SARS-CoV-2 antigen PCR positive only 22%, and negative was 78%. And in the patient who was PCR positive, the IgG serology is percent. And in the PCR negative patient, 98%. It's very, very interesting for us. It's a different appearance, what we can see in the pediatric patients. And the patient who infections with non-SARS-CoV pathogens, mostly they reported none. So the coincidence is very low frequent. And what about in Indonesia? Like Dr. Yogi said, we have local classifications, with the we call it national guidelines, and we focus on the severe and critical care. And we take a look from the adult, because adult populations who suffer ERDS and critical care conditions is more higher incidence. So the incidence of ERDS and outcomes in hospitalized patients with COVID-19 from the global literature survey that is conducted Dr. Susan and a co-worker, they reported and aim to obtain the incidence and better divide the burden from the critical care clinicians. They're doing in January to July. They collected 17 studies from 5 countries, and the result from the 2,486 hospitalized patients with COVID-19 who meets the criteria, and they found the heterogeneity of the types of ERDS. And what they the ICU. In ICUs, 75% have ERDS and 63 receive intensive mechanical ventilations. And the mortality rate of ERDS patients that associate COVID-19 in ICU was 45%. The incidence of ERDS in non-survivor was 90%. The high incidence of ERDS was correlated with the histopathology postmortem examination, like we have always found in the ERDS classically. And it's the same of the COVID-19 patient is a diffuse alveolar damage that predominantly finding. And we know Dr. Gattinoni in the early of the pandemic have presumed about the COVID-19 pneumonia. There is a different phenotype in the respiratory and different treatments because they presume COVID-19 pneumonia two type L and type H. They presume at the beginning COVID-19 pneumonia present with type L with low elastance, low ventilation to perfusion ratio, low lung weight, and low lung recruitability. And if it continue the advanced phase, the type H patients with a high elastance, it means low compliance, high right to left stance, and high lung weight. It remarkable increased lung weight in the order magnitude of the severe IRDS and the high lung recruitability, like classic ARDS. We always found it, and they suggesting the treatment. It's according to the type. If the L type, they suggesting use the like we're always doing in the classic ARDS, but in the H type, like a classic ARDS, but in the L type is a lower tidal volume unnecessary. And there, if we continue in the July, Dr. Gracelli in Italy published a very interesting review from the PubMed. They start from the 457 article that have been knowledge that the patient with COVID-19 that diagnosed with ARDS might not have what we think as a classic ARDS. And from the 301 patients, the from the 7 Italian hospital, they see the pathophysiology of COVID-19 related ARDS injury is similar to that classic ARDS. It's a very different perspective if we compare with Dr. Gattinoni have proposed before, and they found that the complicated the patient of ERDS it associate with the dead space increasingly because related to diffuse microthrombi and pulmonary damage that together with the high D-dimer concentrations make the mortality extremely high. What the implication? Implication is maybe the lung protective strategy with the limitation of tidal volume below 6 ml per kg and plateau pressure to 30 centimeters of water is still recommended. It's very interesting. So we can see here from what they have found, two major finding is the COVID-19 related ERDS have lung morphology and respiratory mechanics that very similar with classic ARDS. It's not same as like Dr. Gattinoni have proposed, and they promote the still use and apply the protective ventilatory strategy. And oxygenation was quantified as the ratio of partial pressure of arterial oxygen to fractional concentration of oxygen-inspired air, or PF ratio. And the ventilation ratio was calculated and used as surrogate of dead space. Ventilation ratio, it might be, can predict minute ventilation, and if greater the one is suggesting the increasing dead space. It's very interesting because dead space, it means high collapse alveoli, make the alveoli cannot compliance. So we can see with the in the figure 3, the Kaplan-Meier analysis, if the patient high D-dimers and low compliance, the mortality increasingly. It's very interesting. And do the critically ill children with COVID-19 were different from adults? The theory is about the difference of the S2 receptor and the different pathogen of response inflammatory in mature, and if there is a competition with other virus like influenza virus, the types, or trained immunity because the children if have been vaccinated, but it's still unproven until we have done and investigated further. What the overwhelming picture of SARS-CoV and COVID-19 children? It's still critical knowledge gap, because the widening disease spectrum and critical knowledge gap, it means it's different in insufficient age and race, ethnic disaggregate, and different in susceptibility and mother to child. We don't know yet is transmission vertical or horizontal, and the predictors of disease progression and the full spectrum of SARS-CoV infection in children remain to define, and we must considering now the post-infectious sequelae such as multi-system inflammatory syndrome, like Dr. Yogi have noticed before. MIC is prominent now because, like Dr. Aman said, mostly in our situation, the baby or the children come to us in the late stage, in the stage 3. There is the hyperinflammation phase. We have always found the children with the sign of ERDS, shock, or cardiac failure. We very, very diminished to differentiate it with the septic shock, or because or due to the other cause like bacterial. But we can see in the stage 3 or the inflammation phase, there's markedly elevated of inflammatory markers like CRP and troponin or D-dimer and ferritin. And since 2015, Palik group, Dr. Neighbor joined us later on. He will explain it in more detail. If we use this criteria to the COVID-19 children, we can see the severity level with oxygenation. It's sign of hypoxemia with the PF ratio below 300 or SF ratio below 206. And the invasive, if the patient got intubation and invasive mechanical ventilation, we use the standardized of oxygen index or oxygen saturation index. And the MISC protocol that proposed with the American New York State Department of Health, we can see the severity grading from mild to severe. It depends on requirement of vasoactive agent and vasoactive score. And from severe, we can see there is evidence of organ injury. And what about it's happened in the children? If MIC, according to the CDC criteria and protocol, there's evidence of post-infection with SARS-CoV-2, and the baby maybe got a fever or headache, a neurological and myocarditis. If the cardiac or hemodynamic compromise, and mostly prominent in the hypoxemia or the respiratory distress. Some patients, some cases with the gastrointestinal disorder or acute renal failure. And if the myocardial damage would happen, there is a decreasing cardiac and pulmonary function. It makes increasingly hypoxia, sign of hypoxemia, and it can be a very prominent myocardial injury sign with the damage of the conduction of the system, and the sudden death, especially sudden cardiac death, it caused by the acute myocarditis or the compensated heart failure, like we have always see. I will explain one of the cases. This is the acute kidney injury from Dr. Akasdev and co-worker in the UK, and they are concluded the prevalence of AKI in MIAC or PIMSTS is high, and most patients develop acute kidney injury in within 48 hours and associated with high BMI and rising of CRP and hyperferritinemia and high pediatric index mortality 3 scores. And what happened with the case of MIST in Indonesia? According to the data from the Task Force of Indonesian Pediatric Society, some of our referral regional have been reported in capital like Medan in Sumatra, Jakarta, Bandung, Surabaya, and Malang from Java, and in East Borneo from Samarinda. I will present only one case, that's like case illustrations in our unit. 2 months old female infant with the history of illness. On admission day until 5 days of admission, the patient came with the breathless and with the sign of pneumonia and atelectasis in the chest X-ray. And because we are suspected in the COVID-19, we isolated her in isolation room with negative pressure for COVID-19 specialty. And after we doing examinations, investigation, PCR COVID-19 was negative twice. The patient moved to the pediatric ward and clinically improved and no fever. But before she will have to discharge, the patient getting worse with the breathless again, the saturation and cyanotic. The patient was intubated in the ward and the transfer immediately to the PICU with the presence of shock, tachycardia, and arrhythmia. This is the chest X-ray at the moment while she is in the this is a lung CT, pneumonia with left upper lobe atelectasis and cardiomegaly, but no perfusions. There is the investigation of the COVID-19. We found nothing in serologic and nothing we found negative in the PCR swab. And this is the clinical timeline from the patients in isolation room, in pediatric ward, and in PICU ward. We can see in the PICU ward, after the patient getting worse again, she need the support of the cardiac support because the warm shock. We doing the ultrasound cardiac output monitoring, a non-invasive assessment, and we found systemic vascular resistance was decreased, and we give the norepinephrine. And this is the chest ray evaluations. But the cardiac output still normal. This is the chest X-ray evaluation and isolation room, while she in the pediatric ward and the PICU at the moment before getting worse. This is the evaluation of blood gas analysis. We can see while she getting worse again in the ward, she got ERDS with the PF ratio below 300, and while in the PICU, getting worse, severe ERDS with the invasive ventilated support with the lung protective strategy. And this is the laboratory while in the PICU. Increasingly, all of the marker of inflammation, and you can see the prolong of the PTR, PTT, increasingly INR, and the increasing D-dimer, troponin T, CKMB, and we found the seroconversion because the IgG of anti-COVID-19 was reactive here after 3 weeks in admissions. And this is the echocardiography assessment several hours before she passed away. We can see this, the right atrium and ventricle dilatation, severe TRs. We found the left ventricle hypertrophy, and it signed of myocarditis and pulmonary hypertension. We do the electrocardiography because the tachycardia in irregular and sometimes bradyarrhythmia. And 30 minutes before she passed away, the patient got complete right bundle block branch, and she passed away. What we have found on the patient is we can see the seroconversion of the serologic and the acute cardiomyopathy and make the sudden death because it's a complete RPP we suggested. So what we have learned from it, because like Dr. Yogi said, COVID-19 make us always learn more and more. So what we see in the predicted critical perspective is we must much more learn about the PRDS, especially PRDS in associated COVID-19, and using implementation of mechanical ventilation in this situation, and cardiac manifestation and hemodynamic compromise in these circumstances, and the incidence of MISC beyond the lungs. It's still a long way to go until we can build and establish a COVID-19 PICU guidelines. And Dr. Saraswati, Dr. Chisti, and Dr. Satoshi, Janhao, and the co-worker have been trying to make and to build PICU guidelines. It can be implemented both for the high or limited resources setting, like have been presented in this slide. Conclusion is in the ventilations, it's a strong recommendation to use supportive oxygenation, like what we always doing to the ERDS classic patients. And to the hemodynamic support, you can see some of the strong recommendation or some of the weak, but the principle is surviving sepsis campaign have been a recommendation. We must consider to limitation fluid bolus only up to until 40 mL per kg in the first patients. And treatment recommendation for invasive mechanical ventilation is maybe after that, Dr. Jackie will explain much more advanced about how can we treat the very hypoxemia refractory with the ECMO for the cardiac and respiratory support. And for the MISC children, the guideline will try to support it with the recommendations. It's still uncertainty because we need investigated furthermore in the with much more studies. But I think we think this is the best practice recommendations. And around Asia, me and Jackie and Judith and Beckman Pediatric Acute and Critical Care Medicine are working still try to find what we will change adapted to infection control and respiratory support in around our region in according to the pandemic. And this is our local guideline. What we have been implemented application since June until now. It might be because this is a living document, maybe it's some kind of revisions according to the best evidence if we have more detail of and the further of the from the literature. And this is my last slide. There is need more of evidence to build and develop the guideline of the critically ill children with COVID-19, and it's difficult. Believe me, every patient were challenging the possibility to change and treat as a learning curve. We so aware of the MISC that acute in our unit, and early diagnosis and management will reach the favorable outcome. And we know it is over. Thank you for the time for me to presentation, and thank you for the moderator.
Thank you, Dr. Riri, for a very clear presentations. We proceed to Dr. Jacqueline Ong. Her topic will be ECMO in cardiac and respiratory support of COVID-19 children. To Dr. Jacqueline Ong, the time is yours. We can hear you, Dr. Jacqueline. Can you unmute your computer? Or maybe your headset.
Bisa dibantu sama mereka, Mas.
Yeah, please unplug your earplug. No, we cannot hear you.
Sorry, Doc. Can you leave the room and enter the room with the same link that we sent? Exit the room first, and then we come back with the same link that we sent. Okay.
Hi, can you hear me now?
Hear you now. Okay, good.
Now you can hear me? I'm so sorry.
Okay, that's okay.
Okay, let me try again. Hi, so can you see my slides as well? Okay, great. Hi, good afternoon, everybody. I apologize for the slight technical glitch. My name is Dr. Jacqueline Ong. I work at the National University. Sorry, can you hear me?
Excuse me.
Yes, we can hear you, but the slide is still off.
Oh, I see. Okay, I know what it is.
turn the screenshot on?
Yeah,
Doc?
I will. Sorry, I think I realized that.
We can help you to share the screen, Doc?
Can you do that?
Yes.
Yes. Okay. Okay.
Okay.
Yeah.
Can you see my slides?
Yeah.
Yes, Doc.
Yeah, you can start then.
Okay. So I don't need, okay, I will work to say, okay, so again, I'm very sorry. I'm Dr. Jacqueline Ong. I work in the National University Hospital in Singapore. Can I just verify you can see my slides now?
It's very clear, so you can start your presentation.
Okay, thank you. Okay. I work in the Pediatric Intensive Care Unit in Singapore, and I thank you for the very kind invitation to speak. I'd like to I was invited to speak on the use of ECMO in cardiac and respiratory support for children with COVID-19. I'd just like to say that I have no disclosures. I'd like to cover a few things about what we know about COVID-19 in children. A little bit, I think the previous two colleagues have spoken about PIMS-TS, or sometimes known as MIS-C. I'll explain a little bit about what ECMO is and what the indications for use are in COVID, and also the important considerations for the use of ECMO in children. Now, I think the previous two speakers have really given an excellent introduction as to what we know about COVID-19. Now, the prevalence in children is generally low. In previous cohorts that have been described, we have in the first cohort that was described in early 2020 from China, that out of 70,000 patients in Wuhan, it was just 2.2%. In Italy, it was 1.2%. And more recently in Australia, they've divided the case mix into 0 to 10 years, and then 3% of cases from 10 to 19 years as of April. And we do know that COVID, if it does impact the pediatric age group, it tends to be the older age group. Children often have very mild symptoms or are asymptomatic, and they're much more likely to get it from a household contact, and they are unlikely to be the index case in a household. Okay. Overall, I'd say that children that require admission to a pediatric intensive care unit is really quite rare. Okay. On the whole, already the majority of cases are adult in each country. Less are children, and of the children's cases, usually only 1 to 8% require intensive care. The majority of these kids unfortunately have comorbidities, such as existing cardiac or respiratory problems, okay? But overall mortality as well remains low, okay? And I'd just like to say that the use of ECMO is rare in most pediatric cohorts around the world, and usually less than 1% of any of the kids that have COVID or those that require ICU care, usually it's less than 1% in what we have available data. Before I go to this slide, I just actually did, unfortunately, I wanted to add that I wanted to share a little bit of data from Singapore. Since the Indonesian Society has been so kind to share the pediatric data from Indonesia. Currently in Singapore, we have just over 58,000 cases overall in the whole country. We've been, I think, very fortunate in Singapore that we've only had so far 28 deaths, all in adults. We have had no pediatric deaths in children. So far, we've had no deaths in children. So far, the pediatric COVID cases in Singapore, we've had about 130 cases. And again, unfortunately, none of these cases have actually needed ICU care. They've been general ward or isolation ward status. I think they may not even have really required oxygen either. So that's the status of where we are in Singapore right now. Now, I think for all the preparation that we did at the beginning of the year for Singapore, there was a mobilization of intensive care unit resources for adults. I think it became clearer that what we thought, that generally COVID-19 in children is mild. We don't really know why as yet, as was alluded to earlier. However, we were sort of breathing a sigh of relief that saying, oh, maybe, COVID-19 in children, the main issue might be isolation, but in general, they're not very sick. Until we came to the 27th of April, there was some of the audience may know, and I think Dr. Yogi is also on Twitter. There was a Twitter alert from the Pediatric Critical Care Society in the UK at the end of April. And this was the tweet. It came out in the evening, all of a sudden, that they saw these rising number of cases of kids with a hyperinflammatory state, and overlapping features of toxic shock seem like Kawasaki disease, and they could be either SARS-CoV PCR positive or negative. And that eventually was known as PIMS-TS, which is Pediatric Inflammatory Multisystem Syndrome, temporally associated with SARS-CoV. So it's a very long name. And then at the end of May, they realized that this was happening in New York as well, which was at that time being very severely affected by COVID. And they were finding that this was happening in American children as well. And they termed it MISC, as has been said. There have been several papers produced about MISC in a very short period of time. And this has already been alluded to, but you will see that there are now currently 3 definitions for MIS or this hyperinflammatory syndrome. There's one from the WHO, which is on the left-hand side, okay? There's one from the UK, from the Royal College of Pediatrics and Child Health, and one from the CDC. What is unifying all of this is that the children all show features of profound systemic inflammation. They're febrile, they often have a rash, they're inflamed. What is of note is that gastrointestinal symptoms seem to be very prominent. The abdominal pain is very common, vomiting and diarrhea. They don't really have the cough and respiratory symptoms already. They have a rash sometimes. But what was also recognized that these children had profound myocardial dysfunction and vasodilatory shock. What was striking also to us, I think right now, in Singapore, we do not have any cases of MISC in children. And in fact, there are very few reports coming out of China of this phenomenon as well. It's hard to know whether or not this is genetic in disposition, or is it just a feature of the fact that some kids are predisposed, or is it just the burden of disease? We don't know yet. But it has been certainly more marked in more marked in the UK and in the US and in certain racial groups. For instance, the Black American or the South Asian group in the UK. And certainly there have been cases, increasing number of cases also seen in India and the Indian subcontinent. I would just like to highlight that because COVID-19 was mild in kids in terms of its respiratory issues, there wasn't really data to support ECMO use in respiratory support, but for PIMS-TS and MISC, this was what was recommended from the Royal College as well as from CDC, By and large, the treatment is primarily supportive, and the use of ECMO is rare, even in this circumstance. This was an excellent paper that came out from Patrick Davies and from the UK group. This was published in July, which sequentially showed that they had 78 patients with MISC from all the UK ICUs that were participating from just over a 6-week period. So a lot of cases, okay. You will see that ECMO use just consisted of 3 patients, which was 4% of all these kids. The rest were supported with standard ICU care, some with non-invasive ventilation, just under half needed invasive mechanical ventilation, but many actually only, about a third just needed either no respiratory support or just oxygen. What was most marked is that a lot of them, the majority of them actually required hemodynamic support in the form of fluid therapy as well as inotropic support. Anecdotally, from friends in the UK who have had to use ECMO for PIMS-TS, they usually recover quite quickly. But by and large, the vast majority do not need ECMO and do quite well just on inotropic support. So just like this, this diagram is really just to show that the vast majority of kids have mild to moderate symptoms. It is usually supportive treatment with regular assessment and usually some isolation. Then if they get a bit worse, requiring hospitalization, then there's other therapy. And if they're critical, they will use this therapy, but really ECMO is right on the tail end of all of this, all right? And just like this is a slide that's courtesy of my adult colleague, Dr. Ram, here in NUHS. ECMO remains in many ways at the tip of the pyramid, okay? With the vast majority of the population of children responding to simple therapy such as oxygen therapy. This is adult data, ventilation paralysis and proning, and ECMO right at the end. So maybe for the benefit of some people in the audience, I thought I'd just give a little bit of an introduction to what is ECMO. So ECMO stands for extracorporeal membrane oxygenation. It's a technique, it's a mechanical technique that provides cardiovascular and respiratory support. It's much like bypass during cardiothoracic surgery. And it can be used to support either the heart or lungs when there's severe failure of either system. And ECMO differs from cardiopulmonary bypass in that there are 2 types of ECMO. There is veno-arterial ECMO, where blood is drained from a large central vein and returned to the arterial circulation. This provides both heart and lung support. The vast majority of ECMO that has been deployed in this current pandemic is veno-venous ECMO, because the vast majority of ECMO has been used in adults with severe ARDS. And in this instance, blood is drained from a large central vein, returned to the venous side, and this provides respiratory support. There is no cardiovascular support in this instance. This is a schematic, a simple drawing, just to show you how ECMO works. If you follow my arrow, a cannula is placed in this instance, this is the right internal jugular vein. Blood is drained away towards the pump. It is oxygenated and CO2 is cleared as well. There's a heat exchanger, and then it's returned through the right common carotid artery into the arch of the aorta. And in this way, you've taken away the requirement of the heart and lungs to work when they are failing. I'd just like to show you some pictures from our setting. So this is a slightly older child, not a neonate, that's been neck cannulated. You will see that she has venous blood draining away from her, and then it's going to the pump and then coming back in oxygenated fashion. This is a picture of the pump setup that we have in NUH. This is a small infant that is another infant who's having ECMO. You will see that there's venous blood coming back down towards the pump. This is the centrifugal pump. It goes to a membrane oxygenator, which is over here. Oxygenated blood is red, bright red, and it's coming back to the patient, which is out of the picture. Just another view of that. Again, this is the venous blood that's coming to the pump head. It's going to the oxygenator. The oxygenator is bathed in a water bath that keeps at a steady temperature so you can maintain the temperature of the child. And then it's returned to the child with the arterial limb. And this is just a picture of one of the rooms. This is an older system. We don't have this system anymore. But you can see that there's a baby behind this. And this is the sweet gas and oxygen blender, which we use to regulate the oxygen and CO2 clearance. Now, as a schematic for veno-venous ECMO, what happens here is that you have deoxygenated blood. This is a 2 cannula strategy where you put a cannula both in the internal jugular vein as well as the femoral vein. And in this instance, there will be blood that's drained away through the pump to the oxygenator and then returned to the right side of the heart. So oxygenated blood enters the right atrium, right ventricle. It does go to the lungs, but the lungs are not functional. So they'll return via the pulmonary veins to the left atrium, still relatively oxygenated, and then go out to the rest of the body. Okay, this is a 2 cannula strategy. There is also what we call a dual lumen, where you insert a single cannula into the right side of the heart. And much like a dialysis catheter, you have venous blood being taken away through the 2 ports in the SVC and the IVC, and then oxygenated blood being returned with the direction of flow towards the tricuspid valve. Okay, so this is another option. Unfortunately, in Singapore, we don't have ready access to these dual lumen cannulas. So the vast majority of children who need VV ECMO in Singapore will have a 2 cannula strategy. Both VA and VV ECMO require cardiothoracic surgeons to insert them because the cannulas often require, at least in our center, the cannulas need to be done under open technique. So I guess looking at what evidence, does ECMO even work for COVID-19? The data is really from adults because right now, very, very few kids are actually on ECMO. And so there isn't much information. So this came from the ELSO registry in late September. This is collating all the patients who are, so the ELSO registry, the Extracorporeal Life Support Organization, is an international registry that centers who provide ECMO can be part of. It's part of data analysis and quality assurance to see how many centers are actually participating in ECMO. This is out of Michigan. Okay. Right now, so far around the world, we have about more than 1,000 patients, the vast majority of which are adult, in 213 hospitals and in 36 countries around the world. Hello? Hi, sorry for the feedback. So we have the mortality 90 days after ECMO remains at about 37%. That's similar to other prior studies of patients who required ECMO after ARDS. And the mortality, of course, if you have increasing age or you require circulatory support, meaning you needed veno-arterial ECMO, is poor. If you are managing on VV, then that's fine. Your outcomes are slightly better. But what's really important, and I cannot emphasize this enough, that your success in ECMO is really dependent on these things. You really need to select the right patient and to time cannulation appropriately. And why I say this is really because there are a lot of principles, general principles in ECMO patient selection, and they're important to note. In general, if we are to consider a patient as a candidate for ECMO, we want to know, is this something that's acute or reversible? If it is, then it's likely that they will get better and can come off the machine. There are certainly very poor prognostic features that we want to know before we cannulate a patient, because you've taken over the function of the heart and lungs. Unfortunately, if you've chosen a candidate that's a poor candidate, then you may be in for an extremely long ECMO run, which can be a drain on significant resources, may not be appropriate for the child, and does not change the child's baseline status. So for instance, if a child has been ventilated for less than 14 days prior to cannulation, then probably a better candidate, because the problem is that there might have been such significant lung disease that recovery is unlikely. So we want to consider if there's been prolonged ventilation. If the child only has single organ involvement, that's a good thing. Or if there's multi-organ failure, then that's a bad thing. The decision to cannulate the patient cannot be too late. So if the patient already has profound hypoxia or the child has needed CPR, then the neurological implications of that are profound, in which case putting a child onto ECMO when they've already had irreversible neurological injury is a bad idea, because you're not going to change their final outcome, unfortunately. And similarly, if there are irreversible disease states, if the patient's got advanced cancer, severe neurological injury, so for instance, a child with severe cerebral palsy, or there's immunosuppression, those are all conditions that we would consider as exclusion criteria for ECMO use. Okay, which is important also because we're looking at maybe a group of children that have comorbidities already. So we have to consider this. Now, to help all the people around the world who are considering the use of ECMO in COVID-19, this was published maybe about 3 or 4 months ago from the ELSO organization. Again, this is a consensus statement by a number of leaders in the field, and to discuss really the appropriate use of ECMO in COVID-19. These are some of the indications that I talked about in terms of pediatric and neonatal indications and contraindications. And you can see that there is a significant list, again, alluding to baseline status and whether or not it's likely to be successful or not. This is, again, generally for adults. This is for ECMO, for respiratory support. It can also be used for children. So what we would look at is really thinking about the pyramid. So if you have a PF ratio of less than 150 millimeters of mercury, things such as prone positioning, the appropriate use of PEEP, neuromuscular blockade, thinking about recruitment maneuvers, those are the things that you would do first, okay? If after those maneuvers you still have poor oxygenation or failure to clear CO2, then you can think about whether or not is there a contraindication to ECMO, no or yes. And if there's none of if with all of these, this doesn't occur, then you continue current management. If your PF ratio is reasonable, but you still have problems clearing CO2 for more than 6 hours, then yes, in that condition, you may consider ECMO as well. Other things that we may look at is an OI, which is an oxygenation index of more than 40 for 2 hours. That's actually, you would have known already sometime beforehand whether or not this was going to happen, because an OI of 40 is really quite high. Or there's significant barotrauma, in which case if you keep applying very high pressures to the lungs, then VV ECMO or this ECMO would be perhaps appropriate. In terms of ECMO for cardiac support, there hasn't been any recent, I suppose, generalized guidelines for COVID, because there's been very few COVID cases that require cardiac support as yet. But in general, we apply ECMO for or VA ECMO for cardiac support when there's progressive cardiogenic shock. You've got myocardial dysfunction, your inotropes are rapidly rising, or you've developed ventricular arrhythmias. And you want to think about this early before the child actually needs CPR or has multi-organ dysfunction. The ideal ECMO patient would be young, which all of our patients are young in the big scheme of things, but no significant comorbidities. You think their disease will get better very quickly, and you've made this decision before they're highly unstable. There are, of course, extra considerations with COVID-19 that we have to think about. This obviously is a picture of no social distancing, but it can't. I put this picture up is really because sometimes when we're cannulating a child on ECMO, it seems like there's so many people in the room. There does need to be a team effort, but this is the number of people that are required a lot of the time when we're cannulating somebody onto ECMO. There'll be the intensive care team, the resident, the intensivist, there would be nurses around, ECMO nurse, there's a perfusionist, a cardiothoracic surgeon, respiratory therapist, and in the background, we need people, porters, we need to involve the call center. These people may not be in the unit, but there's a whole system that needs to be activated when a child goes onto ECMO. And when there's so many people involved and so many people in the room, we really have to be mindful about infection control and the appropriate use of PPE. This comes from the ELSO guidelines that I alluded to, but it's probably best illustrated in this picture, again from my colleague in adults. Right now, we have had ECMO for COVID patients in Singapore, but they've all been in adults. And this is what we've had to contend with. We are fortunate in Singapore that we have several negative pressure rooms, usually in each institution. And this is a adult patient who's in a room with an ECMO machine running. You will see that this person is in a PAPR, which is a positive airway purified air respirator. I'll show another picture of that. And communication is difficult. These two are communicating using a phone or a walkie-talkie, the phone in here and calling out because we don't want to open the door and jeopardize the entire area. We've used whiteboards to signal what we need. It's extremely difficult to communicate in PPE. And so trying to coordinate ECMO effort can be very challenging. In doing so, we've had to run many simulation drills and training for this. This is a simulation drill that was run in our National Center of Infectious Diseases. Our surgeons are all wearing the PAPRs while they're cannulating. It is extremely hot and uncomfortable, unfortunately, as you all know, when working in PPE, we all know this. And trying to coordinate care is very challenging. In preparation for this, these were some simulation drills that I ran along with some other colleagues. It was even resuscitating or intubating a COVID patient involves wearing goggles and making sure that everybody is well protected before coming in. This is the PAPR we use. And we ran this because we knew it would be challenging. And to that extent, even offering ECMO in this situation is worrying. So this was actually an article that was written by a colleague of mine, Dr. Graham McLaren, along with Dale Fisher and Dan Brody. This was early in the pandemic, February 2020, and we already recognized that successful ECMO requires a system of care, even in peacetime. And we worry, and was just the word of warning that ECMO is not something to be rushed to the front line when everything is already stretched in a pandemic. This was actually from the ELSO guidelines again, which talked in much about how we recognize that ECMO stretches capacity. And in conventional capacity already, we carefully select, we offer ECMO for in selected COVID patients. We offer ECMO for non-COVID patients. I won't cover eCPR because that's another kettle of fish, but it's really that we already know that ECMO is really the peak of what we can offer. But when you start running stretched capacity systems where you're trying to optimize outcome, ECMO is really challenging to do in general to really weigh up the risks and benefits of committing a patient onto ECMO and what that will do to the rest of your ICU, your nurses, your doctors, and trying to manage when they already have many other patients that might require their care as well. And what's really been critical also in this pandemic is to also talk about ethical considerations. When would you say that this is no longer working? When are you going to take the child off the machine? If you only have one machine, who would you give it to in the context of a pandemic? And it's really hard. It's really hard to make these decisions. There's a high risk of moral distress and having to make difficult decisions. In some centers, we may consider that after 5 to 7 days, if the cardiac function has not improved, that would be an indication to take the child off ECMO or the patient off ECMO. It's harder to judge for lung recovery because there is well documented, right, increasingly that lungs do take a long time, but you have to decide, is that really going to happen? And trying to decide equity, who to give this machine to. Communication with family is always difficult. It's important at all the time, but in this time where we might reduce caregiver presence or they may not be with their family, it can be really challenging. And providing dignified end-of-life care is one of the things that we struggle with in the face of the pandemic. So in summary, I'd just like to say that the use of ECMO in children with COVID-19 is thankfully rare. But if it is to be successful, we have to make sure that we select the right patient and we time it appropriately. The provision of ECMO is something that requires a complex system of care, and it's not something that we should rush into when everything is stretched during a pandemic. Team training is therefore vital, and we want good and safe ECMO runs for both patients and staff. Okay. So with that, I'd like to thank you very much for inviting me to speak. I apologize again for the technical glitches. I am on Twitter. You can come and find me. And those are my Twitter handles below. Thank you very much.
Thank you, Jacqueline, for your very interesting experience and challenging experience on doing ECMO on COVID-19 children's. Okay, we will come to the last speaker, Dr. Martin Neighbor, and the topic will be caring for the critically ill children, the European Pediatric Society, Pediatric and Neonatal Intensive Care recommendations. To Dr. Martin Neighbor, the time is yours.
Okay, thank you very much. Good morning, everybody. I hope you see my my video. I'm going to put on my presentation. Is it visible?
Yeah, yes.
Okay, great.
Yeah.
So it's a great honor for me to talk a little bit about the ESPNIC recommendations for respiratory support of the child with COVID-19 respiratory failure. And ESPNIC made a document, and I will show you a link later on where it says it's freely downloadable for everybody. So these are my conflicts of interest, none of them related to the topic of this presentation. So I only have about 20-30 minutes, but there's so much to talk about, so I had to make a choice. But I kindly refer you to the ESPNIC website where there is much more available data and literature. So probably it became earlier on this morning, but when we are talking about COVID-19 ARDS, the question is it really different from what we know as ARDS? Is it different from what we know in adults with ARDS? And is it different from what we know in peds? Well, if you look at the adult ARDS, most patients with COVID-19 meet Berlin criteria. So they have abnormalities on the chest radiograph, they have severe hypoxemia, they have increased dead space, and they do have heterogeneous lung disease. So they meet Berlin. But the clinical experiences, and you have seen them as well, is that the ARDS in COVID-19 is more interstitial. There's less potential for recruitment. It seems that the compliance is relatively okay. There is a higher level of dead space. and there appears to be an insufficient hypoxic pulmonary vasoconstrictive reflex. So is it really traditional ARDS or is it different? And the second question is, this is what is seen in adults, but does it happen in children? Well, we really don't know that quite well. And the idea of COVID-19 ARDS being a different clinical phenotype than the traditional ARDS came from a Gattinoni's group earlier on in the Lombardy, Italy area, where they found that adults with COVID-19 had relatively high compliance. So usually in ARDS adults, it's about 35 centimeters ml per centimeter of water, and now they measured a median of 50. But they also measured a high shunt fraction, whereas usually shunt is increased, but not to an extent as what was seen in the adults. And when they put these adults into a CT scan, they found two types of appearances. So in panel A, they found a more patchy, diffuse opacities, whereas in the other group, they found a more traditional ARDS like CT imaging within the dorsal part, atelectasis collapse, in the ventral parts overdistension, and a small area that could safely be ventilated. Whilst these patients more or less had the same PF ratio. So they said, well, there probably are two different phenotypes, and they coined it type L and type H. We're looking at the elastance, and then the type L was the low elastance, meaning the high compliance patient. And those had a low VQ ratio because the hypoxic vasoconstriction reflex didn't work properly. And what that reflex means is that blood is redirected from hypoxic areas to more perfused areas in the lung, but that physiologic response was less prominent in these patients. And because of their high compliance, they had a low potential for lung recruitability. Whereas in the more traditional ARDS, they coined it COVID-19 pneumonia type H, that high elastance, so low lung compliance, a higher VQ ratio, and a more potential for lung recruitability because of the low lung compliance. This made Gattinoni, together with Marini, and I think this slide has already been shown earlier this morning, proposing how you should support those adults with COVID-19 ARDS. But some key features were prominent. Before intubation, they said, well, try to avoid patient self-inflicted lung injury, and I will tell you later on a little bit more about that. And that should be done by attempting a non-vigorous breathing. So try not to have the patient, when on non-invasive support, making excessive respiratory effort. And once on intubation, use your idea of the clinical phenotype to guide the setting. So in those with a type L COVID-19 pneumonia, so the ones with a relatively well-preserved compliance, you should use PEEP, but probably not as much as you would do in those with a more typical ARDS-like image. The elephant in the room, of course, is this really true? Is it so distinct, or is it a clinical spectrum? And probably patients may come in with a type L COVID-19 pneumonia, but over time they may progress to a more type H with a worsening of lung compliance, responding to PROM, maybe better responding to recruitability. So it's not just a simple binary yes or no, but it's a spectrum. And just recently, this paper came out in ICM, where they had 36 ICUs in Spain, and they collected data on all their COVID-19 ARDS patients, and they used the Berlin definition to classify the ARDS. So they classified it according to severe ARDS, moderate or mild. And what they found was that the compliance was actually not that different from what they usually saw in traditional ARDS. So they more or less said, okay, well, we know what the earlier observations were, but well, maybe this is not always the case, supporting the having a clinical spectrum and supporting the concept of the elephant in the room I just showed you earlier on. So taking these considerations into account, well, there are three aspects in COVID-19 ARDS, COVID-19 pneumonia. It's the timing of intubation and the tidal volume and the PEEP I will talk for you today. So the timing of intubation, it's a big question because you don't want to intubate too early, but you don't want to intubate too late. So consider timely intubation whether it's refractory hypoxemia or hypercapnia, and if there's objective evidence of a high work of breathing. So if you have a patient coming in who's hypoxic, and has a work of breathing, and you give oxygen and the patient does well, then it's fine. But if the patient is on oxygen and is still displaying vigorous breathing, making large effort, probably you should move on and intubate this patient. For tidal volume, it's a big question, I would say, because, well, probably if you have typical ARDS, you should be able to go as low as possible to keep your plateau pressure below 30. But if you have a patient with a COVID-19 pneumonia that is more type L, then maybe you can accept a little bit higher tidal volume to meet the patient's respiratory drive. And PEEP was what at least in the adult said, individualized PEEP and identify those patients with potential for recruitment by whatever means you have available at the bedside. Well, since we don't know if it is really that different for children, I think that at this stage we could fairly state that the general principles of mechanical ventilation are not different from non-COVID-19 acute respiratory failure. And we have, of course, the Pediatric Acute Respiratory Distress Syndrome Consensus Recommendations, published in 2015 in PCCM, and they are currently being revised, but the present recommendations are still applicable. We have the PEMVIC recommendations from 2017, and on the ESPNIC website we have a document discussing the practice recommendations from PEMVIC specifically dedicated to the COVID-19 patient. And it's free for everybody, so please go to that website. In this recommendation, we say, okay, if a patient comes in with hypoxemia before intubation, well, we had big discussions. Should you go for high flow? Should you go for CPAP? Both are aerosol generating procedures. But in the end, we recommended that if available, use CPAP because you want to provide some extra support to address the vigorous breathing. And if you don't have it available, then you might consider hyponasal cannula. But whatever means you use as non-invasive support, you have to make sure that you observe your patient. And if there is no clinical improvement in about 1 to 2 hours, then you have to move on and intubate this patient. If a patient comes in with real severe hypoxemia, so let's say an SF ratio below 221, then probably it's not the right way to try non-invasive, but go to intubation immediately. Question is, if we discuss this thoroughly, what is BiPAP, CPAP, or should you use high flow, and how can you identify a one who fails? We don't have pediatric data on that. This is data from adults, where they randomize adults with acute hypoxemic respiratory failure to high flow nasal cannula or NIV. So the high flow nasal cannula was 50 liters per minute. NIV was pressure support targeting a tidal volume of 7 to 10 ml per kg ideal body weight. And what they found was in those with a severe, moderate to severe hypoxemia, so a PF below 200, those who were on high flow had a lower risk of getting intubated than those who were on non-invasive ventilation. And likewise, those who were on high flow had a better survival than those who were non-invasive ventilation. So from that perspective, and we don't have PEDS data, but from that perspective, if you don't have NIV and if you don't have CPAP, high flow is not a wrong approach to use. But as said, high flow nasal cannula, as with any other non-invasive device, is a aerosol generating event. So this is what we published in the recommendation paper that was recently published in PCCM. And it's been alluded to earlier this morning, but high flow nasal cannula, CPAP, back mask ventilation, intubation, extubation, tracheal suctioning, chest physiotherapy, all those events are aerosol generating, and means that if you have a COVID-19 suspected patient or a COVID-19 positive patient, you should at least have your strict PPE. And I think Jackie showed really nice slides and pictures when they did their ECMO simulation. So wear a mask, wear goggles, wear a gown, wear gloves. That's at least the minimum. And if you do have negative pressure rooms, well, you may consider taking care of patients in those negative pressure rooms. Always use cuffed ETTs because you don't want to risk the spill. And if you're going to use non-invasive ventilation, make sure that you use an interface that has an adequate seal. So if available, use a helmet, use a full face mask. Don't just use nasal, use a full face mask that you can really close the patient, make a good seal to prevent spreading of COVID-19. The risk of hypertransmission with non-invasive respiratory support is both there, both for high flow nasal cannula and for NIV CPAP or BiPAP. And there are nice papers on that cited here. And we know from the SARS epidemic early in the 2000s that NIV was associated with an increased risk of healthcare worker infection, calling for strict PPE. We know that high-frequency cannula may increase the distance traveled by droplets, but there is insufficient clinical evidence that it really increases risk of viral transmission. So yes, you can have droplet particles that go on, but at present we don't have data showing an increased infection among healthcare workers. And in the European Respiratory Journal, this nice paper recently appeared where they measured the exhaled smoke dispersion with different oxygen devices and found that for high-frequency cannula, or compared with simple mask or non-veterinary breathing mask, the distance traveled of the particles was more or less the same. So if you don't have CPAP, if you don't have NIV, but you do have high-frequency cannula, don't be hesitant to use high-frequency cannula if you take care of your PPE. So if you have a patient with non-invasive, the next question is how to identify the one who is going to fail. And well, from PEDS, we have this data where they found that the SF ratio was quite good in predicting failure. So this is data from Spain, showing that if the SF ratio dropped within 1 hour, that best identified failure. And we know from the party data that about 50% of those non-invasive ventilation fail. So this simple oxygenation parameter helps you identify the patient who failed. And in adults, we have seen this. We haven't confirmed this in PEDS yet, but in adults, they found that in those with moderate to severe hypoxemia, so PF below 200, the tidal volume patients were generating on non-invasive ventilation was much higher than those who had an NIV success. So meaning that those who were on NIV but still displayed excessive respiratory effort, still displayed vigorous breathing, were more likely to fail. And they made tidal volumes of about 10 to 12 ml per kg, which is really, really high. So that means that the patient is really struggling and really breathing very hard. And this leads to patient self-inflicted lung injury. So the term was there earlier on. So what's happening is you have a patient with impaired gas exchange and a change in an increased lung elastance, decreased compliance. And naturally, the patient starts to increase his respiratory drive because the patient wants to maintain gas exchange. And what then happens is that there will be increased esophageal pressure swings, leading to increased transpulmonary pressure. And this increased transpulmonary pressure is injurious to the lung, causes capillary leak, you get lung edema, and then you enter into this vicious circle because of the lung edema, gas exchange gets further impaired, elasticity further increases, patient starts to increase the respiratory drive, and then etc., etc., etc. And this is a cycle we have to break. And if you do esophageal manometry, you can really see what's happening. This is an animal study from Yoshida, published in CCCM, really nice study, where they looked at mild lung injury on the left panel and severe lung injury on the right panel, with or without spontaneous breathing, abbreviated by SB. And in the middle scalar, you see the esophageal pressure swing. And what they found was the animals that had severe lung injury, that were allowed to breathe spontaneously, had a much larger esophageal pressure swing, a much larger peak to trough esophageal pressure, as a marker of their vigorous breathing. And this excessive breathing resulted in more histological abnormalities. So this is the lung tissue, and on the lower two panels is severe lung injury. On the left is without spontaneous breathing, and on the right is with spontaneous breathing. And those who had severe lung injury and were able to breathe spontaneously had much more inflammation in the lung and a alteration of the lung tissue compared with the mild lung injury in the upper panel. And this challenges a dogma that you should always breathe spontaneously. So yes, of course, if you have mild lung injury, it's fine to breathe spontaneously. But if you have severe lung injury, well, perhaps you should not breathe spontaneously. And maybe one of the underlying mechanisms is pendelluft. And pendelluft means that within one breath, air is moving from the non-dependent zones to the dependent zones in the lung. So what you see is on the right, you see this, the pressure, the swings, and the upper scalar is the non-dependent zone, and the lower scalar is the dependent zone. And at the same time, highlighted by 2 and 4, you see a decrease in volume in the non-dependent zones and an increase in volume in the dependent zones, while the total tidal volume is the same. So this patient is moving air from one part of the lung to the other part of the lung, and this leads to a regional overdistension, to regional stretch. So the first step is to provide oxygen, CPAP, hypertensive cannula, depending on your availability. Do not delay intubation in severe disease and those with excessive work of breathing. So the excessive swings to large tidal volume. Otherwise, the decision to intubate is driven by respiratory system mechanics and degree of work of breathing. And you could question, if you have a patient who has an acceptable work of breathing, maybe you should tolerate a little bit higher FiO2. And recognize treatment failure, looking at the SF ratio and looking at the respiratory drive of the patient. But then if you have intubated this patient, then the question pops up about the tidal volume. And the problem is that in pediatrics, we don't know what the optimal tidal volume is. This is a systematic review of all the pediatric observational data, because we don't have randomized controlled trials, trying to identify injurious thresholds of tidal volume, and we could not identify one. So if you looked at 7 ml per kg, 8, 10 or 12, or if you would compare 7 to 10, 7 to 12, 8 to 10 or 8 to 12, there was no difference in mortality with a single tidal volume threshold. And this was applied to non-ARDS PEDS patients and ARDS PEDS patients. So we don't know what the real tidal volume in children is. PELIC recommends 5 to 7, which is in line with the physiologic tidal volume that we all have, that each mammal has, and going for a lower tidal volume if you have a lower lung compliance. So in Italy, they found that if lung compliance is preserved while tidal volume is higher than 6 ml per kg, could be and should be considered because it was safe, and allowing for a little bit larger tidal volume in those with a relatively well compliance gives you a better CO2 clearance, because these patients have higher dead space fraction because of the microvascular thrombosis. So the oxygenation ventilation impairment is not really due to a low lung compliance and collapsed lung tissue, but it's due to a change in perfusion of the lung. And maybe then you could allow for a little bit larger tidal volume without being injurious. Second thing is for the PEEP. We know that in adults I recommended a relatively lower PEEP if you had a good compliance, and a higher PEEP if you have a bad worse compliance, which of course makes sense. But in PEDS we really don't know what the best way to set PEEP is, and the adults overcame this by defining a PEEP FiO2 table. But the problem with the PEEP FiO2 table is that it is a consensus thing. It's not validated, it's not driven by physiology, and the adults made two tables, a low PEEP, a high FiO2 table, or a high PEEP, low FiO2 table. What we do know is that in children we are more reluctant to use high levels of PEEP. This is data from Robbie Kamani's study with patients admitted to CHLA in Los Angeles or Philadelphia, and where they plotted the FiO2 against the set PEEP and then checked how compatible it was with the PEEP FiO2 table. And they found that in the low PEEP range it was more or less compatible, but as soon as FiO2 got above 0.6, they tended to use high FiO2 rather than increase the PEEP. But if you would plot the high PEEP FiO2 table on the same population, you would see that the PEEP that was given was already much too low. So if we were to go for a table in PEDS, probably we should go for the low PEEP FiO2 table, because the high PEEP FiO2 table may lead to earlier hemodynamic compromise. They found that in their study, if there was a non-adherence to the grid, mortality was increased. So the larger the difference between the set PEEP and the recommended PEEP based on the PEEP FiO2 table, the larger the mortality was, as highlighted by this. And this applied to all ARDS patients, and even in those with severe ARDS defined by a PF below 100. So if we were to use PEEP, then probably the best data we have so far is to use the low PEEP FiO2 table. So, as said, adults recommended low PEEP in type L. SMIC says, well, because we don't know what it's really like in PEDS, use 8 to 10 initial PEEP, and if you use a table, use the low PEEP FiO2 table, but do titrate it by respiratory system compliance, balancing oxygenation hemodynamics. And this is what we always do when we titrate PEEP, so it's not different from COVID-19. consider high PEEP and low lung compliance. And at present, we don't have pediatric data showing that you do better if you use esophageal pressure manometry, EIT, or other monitoring techniques. So we have to use our simple bedside tools available. What does work in adults is prone positioning. And prone positioning works because you get a shape matching. So what's happening, if you look at the upper panel, you see supine. So what's happening is because of the gravity, the superimposed pressure, and the weight of the heart, the alveoli in the non-dependent zone get overdistended, and in the dependent zone get compressed, leading to alterations in the gas tissue ratio throughout the lung. But if you would flip the patient over and put him prone, you get a better shape matching because the heart is now in the dorsal part, it's now below, so there's no compression of the weight of the heart, and you get a better shape matching, leading to a better distribution of the tidal volume and a better distribution of the transpulmonary pressure, leading to a more equal aeration throughout the lung, giving a better gas tissue ratio. It also helps in promoting the perfusion of the lung. So prone positioning is something that really works, and it works in the intubated patient, but it is also beneficial in the non-intubated patient with COVID-19. And it even helps getting the CO2 out. So this is an old study from Gattinoni where they checked, where they examined the effects of prone positioning in ARDS patients on O2 and CO2. And on the left, you see the response in PO2. And although patients might not respond to having an improved oxygenation with prone positioning, which is something we usually see with prone, but despite the absence of an improved oxygenation, there was an improved CO2 clearance, which is shown on the right. So those who responded to CO2 had a better survival. And it's probably because also the perfusion is done. So prone positioning should relatively early be considered in the intubated and the non-intubated patient, not just for improving O2, but also for improving CO2 elimination. So if we were to summarize all the things from PEMVAC directed to COVID-19, well, we don't have PEACH data saying that COVID-19 parts is different from traditional parts, so probably we don't need specific guidelines. So we need to we should adhere to our current existing guidelines. So having a tidal volume of 5 to 7 ml per kg ideal body weight, low if decreased lung compliance, and if you have real CO2 problems, well, 8 is also maybe not that bad. Low PEEP FA2 grid for the PEEP grid. If a low lung compliance, use a higher PEEP. Try to keep your driving pressure. We couldn't go into driving pressure this time, but driving pressure is the ratio of tidal volume over lung compliance under zero flow conditions, which is one of the real injurious stimuli to the lung. Keep it below 50 centimeters of water, retain your plateau pressure below 28-32, and consider supportive therapies like pneumatic blockade, prone positioning if a patient is not improving or if there's mono to severe parts. Because of the changes in the pulmonary and the hypoxic pulmonary vasoconstrictor reflex, if you have a patient who is not responding whatsoever, you could do a inhaled nitric oxide trial and see what happens. If it doesn't work, you can discontinue, but if it works, you can keep the patient on. There has been much debate about high frequency auscultar ventilation, and it would merit a different another talk. But I think that if you have a patient with severe ARDS not responding, there is evidence of poor lung compliance, then you could use high frequency just as you would do it in a non-COVID-19 patient. In the US now, I don't know if it's anywhere available. In the US now, it's available, the inline filtering system on the patient circuit. But if it's not available, you can build your own filtering system to put on the expiratory limb of the oscillator circuit. And if you want, I can email you a picture of it. We have built a custom system ourselves. Well, on respiratory ECMO, I think we had this great talk from Jackie earlier on. The respiratory ECMO should be considered if everything else fails, if you have it available. Thank you very much for your attention.
Thank you, Dr. Leiber, for a very impressive lectures. Okay, so we come to the discussions. Okay. So anyone wants to ask questions, you can go ahead or put your question in the chat sections. I already have some questions. The first one is from Dr. Kartika Saraswati. I think this question is dedicated to Dr. Yogi, but anyone wants to give opinion is very welcome. Yeah. The question is what causes the high age-specific mortality in Indonesia? Do we have higher rate of comorbidities or malnutritions, or is mainly because of the limited facility? Dr. Yogi, can you answer the question?
Sorry, Doctor.
The question is, what is the cause of a high mortality in Indonesia, age-specific mortality? Is it because of the comorbidity, or is because of the limited facilities?
Yeah, a very excellent question. And actually, these questions already really blowing our mind during this pandemic here. At the beginning of the pandemic, probably like everywhere else in the world, we are we will have maybe a lack of awareness there of this kind of patients, and sometimes we see that there is a delayed treatment. You remember the idiom about there is no emergency in pandemic? It is true, and it is still true until today. But then, once we are afraid to give adequate management in an emergency and critical patient, and we know that it's very time sensitive, then there will be a delayed treatment. I myself already experienced this kind of situations when once the patient, we start on high flow nasal cannula, let's say, and then it's failed. When we think about intubation, then we have to put on PPE and all that, and sometimes we still afraid about the localization. This happened in the past. For nowadays, we see there's quite a different proportion of case fatality ratio within the children with comorbidities and non-comorbidities. So I think comorbidity also have this role. And then we know that Indonesia have a double or even triple burden here. Before the pandemic itself, we have quite a proportion of children with malnutrition and stunting, and we know that the biggest five of comorbidities that we managed to collect from the IPS COVID-19 data registry is malnutrition. But I think we are still searching. We are still have this discussion with all the experts, with all the pediatricians that managing this kind of patient about the cause why Indonesian children is more prone and why our case fatality ratio around 0.45% is highest in the region. Thank you.
Thank you, Dr. Yogi. Dr. Riri, do you want to add some things to these questions? Okay. Okay, if there is you don't have any more answer, then or comment, I will proceed to the next question. This question came from Dr. Agung Gautama, and this is dedicated to Dr. Riri, I think. But anybody, all the speakers can give comments, of course. Yeah. The first question from Dr. Agung is, if COVID patient having fever, lost appetite, what is the laboratory should be request? And he also asked about the do we need to measure the vitamin D levels? The second question is also from Dr. Agung. What is the signs that we need to be aware of COVID patient that will develop the MISG?
Okay. Thank you, Dr. Anton. I will try, and thank you, Dr. Agung, for the questions. I think I tried to answer the question one. Please correct me if I wrong about the questions. Dr. Agung asked about if COVID patients having a fever. I think one of the signs most prominent, almost half of the patients coming to our institutions or our center, and from all of the literature and report from regional or from Europe, or I don't know, from Asia part 2, like China, the most prominent of the infections, mostly in the moderate and severe level, is fever. So I think it's one of the main symptoms of the COVID-19 patients. And about the vitamin level, we need to explore more the participation or correlation between vitamin B with the ferritin, I think, but it needs more investigation. I don't know, maybe Jackie or Martin can help me to answer these difficult questions. And the second questions is the sign of awareness about the COVID-19 if the patient or the baby having MISC. In our experience now, nowadays, there's increasingly awareness about the MISC because we are in the after almost 1 year after the beginning of the pandemic. Maybe most of the children have exposure from the COVID-19 infections, and they have post-infections reactions. That's the basically principle of the MISC. So we must concern if we suggesting the baby or the patients getting or having MISC or not. Please recall the history, but I know it's difficult. And we can trace it with the serologic, with the antigen, and maybe if we can examine the antibody serologic of COVID-19 is better. And we can see the IgG or IgM reactive or seroconversion, like what we have found in our unit. It's a tracing in the post-infection, and we are tracing the sign like the three definitions, what CDC or Royal or the with the WHO. I think it's not a very difference, but only consider about the level of severity. There is more or less the organ dysfunction. I think that's from my side. Maybe Martin and Jackie or Dr. Yogi can edit more. Thank you, Dr. Anton.
Okay, thank you, Dr. Ria. I would like to hear your experience or comment from Jacqueline and Martin. Do you regularly measure the vitamin D levels in COVID patients? Jacqueline, please.
Hi, yes. I have to say, no, we don't usually measure vitamin D levels in COVID patients. Having said that, I have to also fully recognize that at the moment, I guess in Singapore, the vast majority of our kids are very well. They're mild symptoms, so we wouldn't necessarily pursue a lot of the blood tests if they are otherwise quite well. With respect to the second question about whether or not there are features that predispose or might give you some clue that a child with COVID will develop MIS-C, I don't think there's very much in the way of prediction, apart from perhaps that certain genetic or racial groups have a certain predisposition. But I can't say that if you had primary COVID infection that you would necessarily have a clue that this patient would get MIS-C. I think the challenge is that MIS-C is still a condition that we are learning a lot about. It has a lot of overlap with other conditions. And I think in our context in Asia, I think we can't exclude sepsis as being something that it can certainly overlap very strongly with septic shock or severe sepsis. So I think that's something that we need to be mindful of as well. Yeah.
Exactly.
Yes.
Martin, do you want to add another comment?
Yeah, I think the what Jackie described is more or less the same for us. Unfortunately, we rarely see really sick kids with COVID-19, and I must admit, even in the non-COVID-19, we really don't regularly measure vitamin D. So I'm not a real expert on that one. And for the MIS-C, it is so complex and so difficult. And then you have this link with a proven or suspected COVID-19 infection or whatever. And I think the UK people nicely proposed a algorithm in the Lancet Child Adolescent Health recently, when to use IVIG and when not, and when, because it has similarities with Kawasaki and other symptoms and with sepsis, as Jackie said. So it's such a novel thing that we need so much to learn about. The only thing what we now do is when we do get a kid in the unit in these days, I tell the residents and the fellows, well, keep in mind that it might be COVID, keep in mind that it might be MIS-C. And I think that's probably one of the first things we have to do, get that awareness.
Okay, thank you, Martin. We have a very limited time, so I think I will proceed to the next questions. This is a question from Dr. Niken Wahyu. She's asking about any consideration before prone position. Should we do an echocardiography? So I think this is for Dr. Martin Neighbor.
I'm sorry, the sound was a little gibberish.
The question is regarding the prone position. Is there any consideration before doing the prone position? Should we do an echocardiography before doing the prone positions?
I couldn't hear you. I just maybe someone can the WhatsApp the question, then I can respond.
Martin, can you hear me?
Do you have the same, that the sound is vibrating, or is it?
Or maybe, Jacqueline, you can share your experience with the prone position.
Sure. Martin, can you hear me? The question is whether or not we would consider any particular considerations prior to prone positioning. I guess I would apply the same principles that I would do for any patient that I would consider proning, and this is usually in children who have severe ARDS and in whom I want to recruit. I think the main thing with prone positioning that it has to be done safely. When we turn children over, we have to be mindful that obviously by this point they're intubated, and making sure that all the lines and tubes are in place. I don't normally do an echo prior to prone positioning, in the sense that I would have also a sense if the child is shocked or has on a high dose of inotropes, and or the child is very unstable and I think the child might arrest, then prone positioning would probably be taken with quite a lot of caution. But I don't routinely echo children before prone positioning. I think prone positioning works wonders. I think it works amazingly well when they're very hypoxic. But I think there's often a concern about safety in terms of lines, tubes, and making sure. And the last thing that my nursing colleagues are usually very concerned about is pressure areas. For instance, the kid will be lying usually they're trying to support the head. They're usually supported on their chest and their hips. And so skin breakdown is a concern for the nurses as well. And so we work very hard in terms of trying to make sure that doesn't happen. Yeah.
Yeah, I think that's very important question. Do you want to add something?
Yeah. The sound is fine now. Thank you. So, and I got the questions through the WhatsApp. So, we don't do cardiac ultrasounds regularly as well before putting prone. I think one of the things when you go to prone positioning, it's really good to have a checklist, and it's something you really have to practice regularly with your team in scenarios, because you have several team members that are present during proning, and you have one dedicated team member who's doing who's the airway management and keeping the endotracheal tube in place. And if you go to the Prospect website where we do from our international high frequency prone positioning trial, we have prone positioning protocols, and they are freely available for you. So they are really step by step saying, okay, this person should do this, and then this, and then this, and you should position a padding on these areas to prevent pressure ulcers, etc. And it's a really nice checklist and it's freely available. So if you want to go there, then you can take a look at it, and maybe you can use something that in your practice. But again, it's for proning. It works really well. I oscillate a lot, so I don't prone that often, but I do prone when they're on the oscillator. But it's a team effort, and it's something you really need to practice regularly.
Okay.
Can I just add one thing as well with proning? Sure. So there are actually so adults with this current COVID pandemic, adults have really bought into proning, and so because there are obviously a lot bigger, proning an adult is not easy, but they do it, and there's several resources online. There's if any of you in the audience are active on Twitter or social media, right at the beginning of the pandemic, there were several hospitals that put up their how they prone videos on Twitter, and they actually literally often use the bed sheets. They will create basically a package, and then they will flip the patient over. So there's lots of actually resources online, because at the beginning of the pandemic, everyone was so hungry for information. There was a lot of sharing about what to do. So I think if you're interested with the techniques that different hospitals have attempted, it is readily available online for safety, and if they can do it in adults, we can do it in children. Yeah.
We even had when we admitted adults to our unit in the first wave. We had firefighters staying in the unit to help us with proning the adults.
Okay.
Thank you for your comment, Jacqueline. Okay. There are still a few questions, but I think we come to the end of the, because of the time, we have to close this meeting, the scientific meeting. So I would like to thank you for all speakers for the lively discussions, and also to all participants who are still following this online symposium at the very end. So we will see you again in another online symposium from the Indonesian Pediatric Society. Thank you very much.
Thank you very much.
Thank you very much.
Thank you for inviting. Thank you very much.
Thank you.
Have a good day.
Thank you for watching us.
To Yogi. Thank you.
Yeah.